Yeah. Dr. Han?
So sorry. Still Dr. Han's thunder.
Thank you. If you can join us. And he's going to talk to us about long-term results for EVAR. How should we interpret the DREAM randomized controlled trial and the EVAR-1?
Good morning. Thank you so much. It's a real honor to be speaking alongside some of the real leaders in vascular surgery, so thank you so much for the invitation to speak today. The task I've been given is to discuss some of the updates and the long-term results of endovascular aneurysm repairs. I have no financial disclosures. In particular, when we talk about randomized controlled trials that compare the effects of the results of endovascular repair versus open repair, there's really four that we talk about. The DREAM trial, the EVAR-1 trial, we'll talk about these in more detail. The OVER trial, which was the US study from the Veterans Hospitals, ACE, the French trial. And kind of the theme from the early results in the first 2-year period is about the same across the board. There's initial perioperative 30-day morbidity and mortality benefit for endovascular aneurysm repair, but that difference kind of disappears when you go out to 2 years with no survival benefit with endovascular repair. A lot of studies have shown increased risk of late rupture and more reinterventions with EVAR, questioning the durability of endovascular repair long term. Recent publications from the DREAM trial, which you can see up here, 2017 in Journal of Vascular Surgery, and the EVAR-1 trial now presents over 10-year data in an attempt to answer the question, is endograft repair of an abdominal aortic aneurysm really durable? And that's what they kind of sought out to see. The DREAM trial was a randomized controlled trial from the Netherlands and Belgium where they randomized patients with aneurysms greater than 5 centimeters, 173 to EVAR, 178 to open repair, and they followed them up for a median follow-up of 10.2 years, which is really remarkable for these patients. There was no significant difference for all-cause mortality between the two population groups, and the aneurysm-related mortality was similar between the two groups as well. The initial benefits that they had published about at 6 months disappeared, and EVAR and open repair did the same in the long term. What they did show significance for was a higher rate of secondary interventions with endovascular aneurysm repair, with a significant p-value, 21.1% for open repair, 37.8% for endovascular repair. And reintervention, however, despite the increased rates of reintervention-free survival was similar between the two studies as well. So their conclusions was no survival difference between open repair and endovascular repair, and there's increasing numbers of reinterventions with endovascular repair. The EVAR-1 study was a UK study with 1,252 patients that they randomized to EVAR and open repair with a median follow-up of 12.7 years, another remarkable attempt. And their results are similar. All-cause mortality similar between the two groups, 9.3 deaths per patients with EVAR, 8.9 deaths per 100 person years in open repair, and the same thing where the initial benefit seen in the first 6 months with EVAR decreased after. This should re-decrease, I apologize. Initial benefit goes away with endovascular aneurysm repair and actually ends up doing worse. And we'll go over that more in detail. Aneurysm-related mortality, no significant difference between the two groups. And the real conclusion that they reached in their long-term trial was that after 8 years, open repair actually does better with lower total mortality and lower aneurysm-related mortality, both with a statistically significant p-value. They attributed that to increased aneurysm-related mortality in the EVAR group after 8 years is attributable to secondary sac rupture. And they show reintervention rates that's very significantly different, with EVAR reintervention rates of 23% and open of 8.8% with a very significant p-value. And their conclusions were that EVAR has early survival benefit, EVAR has inferior late survival compared with open repair, and EVAR needs lifelong surveillance and reintervention if needed. But really the results are not really what they seem, and you have to look at the actual details of the study before you reach any kind of conclusions that they arrive at. The first kind of thing that we have to look at is the type of grafts that were used in the studies for both of them. We've seen this kind of FDA timeline of what kind of grafts have been available to us since the advent of endovascular aneurysm repairs. There's a couple up in the front that have been taken off the market. The Ancure graft, highly known for their graft occlusions, was already taken off the market. These two particular grafts, Anurex, which had no kind of active fixation in the graft, had the highest rate of migration on the market. And then Talent, which also had no active fixation and just had the bare metal springs, had the second highest rate of migration. In the DREAM trial, when we look at the grafts that were actually used, just under 50% were grafts that were already taken off the market. So only the Cook Zenith and the Gore Excluder that we still have on the market are the ones that are being studied. EVAR1 trial has a very similar issue. So when you look at the grafts that they used, just 58% of the grafts that are included in this study are the ones that have been included for their long-term follow-up. So when we look at what the DREAM results were showing, secondary interventions most commonly performed for loss of aneurysm exclusion because of graft migration and endoleak and limb occlusion. It's probably a testament to the fact that some of these grafts are just not on the market anymore. And if we look again at the rate of secondary intervention, that's a massive rate. 37.8% of patients who undergo endovascular repair requiring a secondary intervention. This might be more of a reflection of the suboptimal grafts that were used initially. So analysis with exclusion of discontinued grafts would provide more relevant long-term data for us. Not all reinterventions are included. Particularly in the EVAR1 trial, this very, very significant p-value with 23% versus 8.8% looks very significantly different. But this reintervention rate does not include incisional hernias and wound infection that are often associated with laparotomies and for open repairs. The OVER trial, I'll just briefly mention, is that when they include incisional hernias into their cohort, the OVER trial actually showed no significant difference in rate of reintervention, 22.1% for EVAR and 17.8% for OR. So really, if EVAR1 included these kind of results, it might be more telling for us. So my conclusions when I read these two studies, even with the old grafts, endovascular aneurysm repair provides improved perioperative outcomes and comparable survival to open repair. Rates of reintervention were higher with first-generation grafts, so it's a good thing they're not on the market anymore. And it is hard to provide long-term data in a field that has seen significant advances in the last decade. And Dr. Veith, whenever he talks about any of these studies, always talks about this. Randomized controlled trials and level 1 evidence are not always the infallible holy grail they are cracked to be, and I do believe that this is a very true statement. Thank you very much.